Welcome back to our latest installment of our PMHNP certification exam preparation series. I'm Dr. John Rossi, your host and guide, presenting this complimentary segment derived from our weekly live sessions offered by Clarity Education Systems. Our mission is to empower students preparing for the psychiatric mental health nurse practitioner certification exams with the knowledge, skills, and confidence essential for success, both on the exam and in the clinical practice. Each Wednesday at 7 p.m. Mountain Standard Time, we convene with our enrolled students to explore practice questions, dissect rationales, and address the challenges of this rigorous journey. This series provides a window into that experience, offering valuable insights for all aspiring PMHNPs. Let us proceed with today's session, designed to strengthen your preparation and deepen those understandings. So, the first question here, we're going to take a closer look at how we apply epidemiological data to guide assessment and treatment. As a matter of fact, we're going to do that throughout this entire session. So, looking at this one, we're going to be talking about major depressive disorder, or MDD. In this case, we highlight the importance of knowing the statistics and the patient's story. The question reads, a 35-year-old female presents to your clinic reporting persistent sadness, anhedonia, and fatigue for 6 months. She has no prior psychiatric history, but mentions a recent divorce and a family history of depression. As a PMHNP, you consider the epidemiology of major depressive disorder, which has a lifetime prevalence of approximately 16 to 20% in the U.S., with women being 1.5 to 2 times more likely to be affected than men, and risk factors including family history and stressful life events. Which of the following best applies to this epidemiological data to guide your initial assessment and intervention? So at this point in the lessons and in the seminars, we would go over each one of the test-taking strategies as we walk through this question. Option A, assess for MDD using a standardized tool like the PHQ-9, explore her family history and divorce as risk factors, and initiate sertraline 50 milligrams daily. Option B, attribute her symptoms to divorce, recommend supportive counseling, and monitor her symptoms for 1 month without further assessment. Option C, screen for bipolar disorder, as women are more likely to have mood disorders, and start lithium 300 milligrams BID. D, focus on her fatigue as a primary concern, order a thyroid panel, and delay psychiatric assessment until medical causes are ruled out. Think about her symptom profile, the duration, and risk factors. Which response reflects a solid, evidence-based clinical approach based on population data? All right, if you chose A, absolutely right. Let's talk about why. So this patient has had core symptoms of MDD, such as sadness, anhedonia, and fatigue for 6 months, which clearly meets DSM-5 criteria for further assessment. Epidemiologically, we know that MDD affects about 16 to 20% of people at some point in their lives, and women are 1.5 to 2 times more likely to experience than men. Her recent divorce and family history of depression further increase her risk. So using the PHQ-9 allows for a structured, validated screening tool that not only aids in diagnosing, but helps track severity over time. Starting sertraline or Zoloft at 50 milligrams is an evidence-based first-line SSRI, or selective serotonin reuptake inhibitor, treatment. It's effective, well-tolerated, and appropriate for moderate depressive symptoms. So this approach reflects both population data and individualized care. All right, so let's break down why the other options don't quite fit here. So B, attributing symptoms to divorce and then delaying the assessment. So this really downplays the significance of her symptoms. Emotional triggers like divorce can contribute to depression, but they don't exclude a diagnosis. Waiting a month without formal assessment risks prolonged and suffering. All right, option C, that screening for bipolar disorder and starting lithium. So while it's true that women are more likely to experience mood disorders, this patient doesn't report mania or hypomania, which is essential for diagnosing a bipolar disorder. So jumping to lithium bypasses the appropriate starting point. And then finally, option D, focusing on fatigue and delay in psychiatric assessment. So sure, fatigue can have medical causes like hypothyroidism, but in this context, with sadness and anhedonia, you start with psychiatric evaluation. You can screen medically alongside treatment, but you don't need to delay care. All right, so epidemiology, it really helps us anticipate what's likely, but it never replaces a thoughtful, structured assessment. So the key takeaway here is we use epidemiological data to guide structure assessment, not delay it. When risk factors line up with clear symptoms, don't delay. Use tools like the PHQ-9. We could also use the Beck. We could use the BDI. We want to explore that full picture. We could also utilize the HAM-D, and this is going to initiate evidence-based care. All right, great work on this first one. Let's go ahead. The next question is going to dive into the early identification and management of schizophrenia, something PMHNPs must handle with confidence and clarity. We'll also see how epidemiological data helps us make smarter, faster decisions. The question reads, a 24-year-old male presents with a 4-month history of auditory hallucinations, social withdrawal, and disorganized speech. He has no prior psychiatric history, but reports a family history of schizophrenia. As a PMHNP, you consider the epidemiology of schizophrenia, which has a lifetime prevalence of approximately 1% globally, with a higher incidence in urban environments and among individuals with a first-line relative with the disorder. It's about a 10% risk. Which of the following best applies to this epidemiological data to guide your initial assessment? Option A, diagnose schizophrenia based on his urban residence and initiate risperidone 2 milligrams daily and refer him to a case manager. Option B, apply the positive and negative syndrome scale or the PAN-SS, explore his family history as a risk factor, and then initiate aripiprazole or Abilify 5 milligrams daily. C, attribute his symptoms to urban stress, recommend mindfulness exercises, and monitor for 1 month without medication. Or D, screen for substance use as a primary cause, order urine drug screen, and go ahead and delay antipsychotic treatment until those results are available. All right, so look at the data, look at the symptoms. What's the best initial step based on what we know about the risk and the population and the presentation? All right, in this case, if you chose B, absolutely right on target. Let's break down why. So this patient presents with the hallmark features of schizophrenia: hallucinations, social withdrawal, and disorganized speech. And it's been going on for 4 months. That puts us firmly within a DSM-5 territory for a possible schizophrenia spectrum disorder. Now, keep in mind, we're only at 4 months, and to receive a schizophrenia diagnosis, there does need to be 6 months history. Okay, so we're talking about a different schizophrenia category right now. Let's connect the epidemiology to clinical judgment. So lifetime prevalence of schizophrenia is around 1% globally, right? But with first-degree relatives, that risk jumps to 10%. Living in an urban environment is also a documented risk factor. So by using that positive and negative syndrome scale, you're taking a systematic, evidence-based approach to evaluating system clusters. Initiating Abilify at 5 milligrams daily is appropriate as a second-generation antipsychotic, often chosen for its favorable side effect profile, especially important for young adults. All right, let's talk about those other options and why they missed the mark here. So A, diagnosing based on that urban residence. So yes, urban environments are a risk factor, but diagnosis requires DSM-5 criteria, not demographics alone. Also, while risperidone is effective, it's associated with more prolactin elevation and EPS, which may be less ideal for a first-line option in younger patients, especially a male. Option C, attributing symptoms to urban stress and recommending mindfulness. So mindfulness, it can be supportive, but delaying treatment for 4 months ongoing psychosis risks disease progression to that actual schizophrenia diagnosis and obviously a poorer long-term outcome. So the earlier we treat, the better the prognosis. And then finally, option D, screening for substance use and delaying antipsychotics. It's always wise to screen for substance-induced psychosis, especially in a patient like this where, we've got a male in this particular age range. That's something that we definitely want to look out for here. a 24-year-old or in those college years could definitely show up with some type of drug-induced complication. But we have to consider, especially with a strong family history and classic symptoms, that's going to be more risky. So you can begin treatment while still ruling out other parallel issues that may be going on. So the key takeaway here is use epidemiology to inform, not replace diagnostic criteria. So epidemiology gives us a clinical edge. It tells us where to look closer, what to anticipate, and how to manage risk. But diagnosis always comes before the symptoms. Or I'm sorry, comes from those symptoms, not before. We want to look at the symptoms first. All right, pair the two together, and you'll be delivering this better, more excellent care in a timely manner. So you're doing awesome here. Let's jump into that next question and see what we're dealing with. So we're going to be looking at a case that brings us into one of the most common areas PMHNPs manage, anxiety disorders, with a lifetime prevalence of around 31% in the US. It's something every provider must recognize early and manage effectively. So let's take a closer look. The question reads, a 20-year-old female presents to your clinic reporting excessive worry, restlessness, and difficulty concentrating for 8 months. She denies trauma, but mentions a recent promotion that increased her work stress. As a PMHNP, you consider the epidemiology of anxiety disorders, and which have a lifetime prevalence of that approximately 31% in the US, with women being twice as likely as men to be affected. Often linked to social and occupational stressors. Which of the following best applies this epidemiological data to guide your initial intervention? Option A, attribute her symptoms to work stress, recommend relaxation techniques, and monitor her symptoms for 1 month. Option B, screen using the HAM-A, explore work stress as a risk factor, and initiate buspirone or Buspar at 10 milligrams BID. C, diagnose adjustment disorder due to her promotion, start supportive therapy, and reassess in 2 weeks. Or D, focus on potential trauma despite her denial, initiate trauma-focused CBT, and order a cortisol level test. Now look closely at the duration, the symptom profile, and the risk factors. What aligns with best practice for a PMHNP? All right, if you answered B, absolutely. Let's break it down. You've got it. So in this scenario, the patient's symptoms, excessive worry, restlessness, and concentration issues, this has been lasting for like 8 months. So this fits that clinical criteria for generalized anxiety disorder, or GAD. Epidemiologically, we know that 31% of adults will experience an anxiety disorder at some point in their lives. Women are twice as likely to be affected, and occupational stress is a well-known factor. So using a standardized tool like that Hamilton Anxiety Rating Scale, or the HAM-A, this is going to help provide an objective baseline and guidance towards those treatment decisions. And remember, with the HAM-A, we're looking at both somatic symptoms related to anxiety as well as the psychological. It's one of those clinician-administered screening tools. Now, using Buspar at 10 milligrams BID, this is a smart initial choice for GAD, okay, especially when you want to avoid the risk of dependency associated with benzodiazepines. So Buspar is FDA approved for GAD, and it works best when anxiety is chronic, but not accompanied by any panic or depressive features. All right, let's talk about those others and why they fall short here. So option A, attributing the symptoms to work stress and then delaying action. So work stress, it can trigger anxiety for sure, but it doesn't mean the anxiety isn't, a disorder itself. And then waiting a month without screening risk misses and delays that opportunity to treat, so especially when we're been suffering for 8 months at a time. So option C, diagnosing adjustment disorder. Adjustment disorder is a short term, right? It's directly tied to a specific identifiable stressor. But this patient's symptoms have lasted beyond 6 months, which exceeds the diagnostic window. Her symptoms profile more consistent with generalized anxiety. And then option D, assuming trauma and ordering a cortisol level. So she specifically denies trauma, and there's no indication for PTSD here. Jumping to trauma-focused CBT or labs like cortisol, this can misdirect care. and ignore the more statistically and clinically likely diagnosis, GAD, triggered by life stress. All right, so our key takeaway here is going to be epidemiology guides screening, but symptoms confirm the path. So this is a textbook case where the epidemiology supports the diagnosis, but it's the clinical interview and the assessment tools that really seal it. Always screen, always confirm, and when appropriate, treat early. Your patients don't need to suffer longer than they have to. All right, excellent job. Keep your clinical response and reasoning sharp. Let's move on to that next question. So let's take a look at a case that many PMHNPs encounter. This is PTSD in a veteran. So this scenario highlights how epidemiological knowledge and data can sharpen your clinical decision-making, especially in trauma-informed care. The question reads, a 40-year-old male veteran presents to your clinic reporting nightmares, hypervigilance, and avoidance of crowded places for 6 months following a combat deployment. He denies prior psychiatric history, but mentions a history of childhood abuse. As a PMHNP, you consider epidemiology of post-traumatic stress disorder, which has a lifetime prevalence of approximately 6 to 9% in the U.S., with higher rates among veterans, up to 20% higher, and those with a history of early trauma. Which of the following best applies this epidemiological data to guide your initial management? A. Attribute his symptoms to combat stress, recommend mindfulness exercises, and monitor for 1 month without further assessment. Option B. Screen using the PCL5, explore his combat and childhood trauma as risk factors, and initiate sertraline 50 milligrams daily. Option C. Diagnose adjustment disorder due to his deployment, start supportive therapy, and reassess in 2 weeks. Option D. Focus on his childhood abuse as the primary cause, initiate trauma-focused CBT, and delay PTSD screening until trauma history is fully explained and explored. So what do we do when a veteran presents with classic PTSD symptoms and a known risk factor? We look for the option that reflects both clinical and epidemiological awareness. All right, if you selected B, screen using that PCL5, absolutely right. Let's break it down here. All right, so this veteran presents with nightmares, right? Hypervigilance, avoidance, classic features of PTSD, and it's been going on for 6 months, which means DSM-5 criteria are definitely met here. Now let's bring in the epidemiology. So PTSD has a 6 to 9% lifetime prevalence in the general population. Among veterans, that number jumps to what? 20%, right? A history of childhood trauma is a known compounding risk factor, increasing susceptibility and severity of PTSD later in life. So using the PCL5, this is a validated 20-item PTSD checklist aligned with the DSM-5 criteria, ensures a structured and evidence-based screening. So exploring both combat and early life trauma helps build that trauma-informed care plan. So starting Zoloft or sertraline 50 milligrams is appropriate. It's FDA approved for PTSD, well tolerated, and it's effective in reducing re-experiencing arousal and avoidance symptoms. All right, let's take a look at those other options. So A, attributing symptoms to combat stress and then delaying. So combat stress, it definitely is it's definitely a part of this picture, right? But dismissing the symptoms without screening is going to risk underdiagnosing PTSD. So waiting a month with no structured evaluation, it's clinically, it just isn't clinically responsible. You're not doing the right steps. Option C, diagnosing adjustment disorder. So this minimizes that chronicity and the specificity of his symptoms. PTSD isn't a general stress reaction. It has a defined symptom cluster and requires targeted treatment, not just supportive therapy. And then option D, focusing on childhood trauma and delaying screening. So while early trauma, it's important, the primary trigger here is his combat experience. Delaying PTSD screening until his full trauma history is explored misses the urgency of treating current symptoms and delays relief. So our key takeaway, PTSD equates to validate trauma plus screen early plus treat promptly. When patients, especially veterans, Open up about trauma. Our job is to listen, validate, screen, then act. Don't delay diagnosis because of multiple trauma layers. Start with what's happening now and build from there. Your work matters, and so does the care you provide in these high impact situations. All right, incredible job. Let's take what we've learned and move forward to our next case. So let's close out the session today with a case that highlights the importance of early detection and careful intervention in bipolar disorder. This diagnosis often emerges in adolescence or early adulthood, and when missed, it can lead to a serious consequence from the wrong treatment path. The question reads, a 19-year-old female college student presents to your clinic reporting a 2-week period of elevated mood, decreased need for sleep, and impulsive spending, followed by a week of low mood and fatigue. She has no prior psychiatric history, but reports her mother has bipolar disorder. As a PMHNP, you consider the epidemiology of bipolar disorder, which has a lifetime prevalence of approximately 1 to 2% in the US, with a peak age of onset between 15 and 24 years, and a strong genetic component up to 10% risk with a first-degree relative. Which of the following best applies to this epidemiological data to guide your initial intervention? Option A, diagnose bipolar disorder based on her age, initiate that lithium 300 milligram BID dose, and refer her to CBT group. Option B, attribute her symptoms to college stress, recommend sleep hygiene education, and monitor for 1 month. C, screen using the MDQ or the Mood Disorder Questionnaire, explore her family history, and initiate lamotrigine or Lamictal 25 milligrams daily. D, focus on her depressive symptoms. Start sertraline 50 milligrams daily and reassess her mood in 2 weeks. All right, she's young, showing classic mood fluctuation symptoms, and has a family history. What's the most clinically responsible next step? Not just based on symptoms, but on epidemiological risk. All right, if you answered C, screen using the MDQ, explore family history, and start lamotrigine, you're absolutely right. So this patient's episodic elevated mood, reduced need for sleep, and impulsivity, followed by a depressive week, is suggestive of bipolar spectrum disorder, likely bipolar 2, especially with her age 19 and a first-degree family history, which increases her lifetime risk, remember, by 10% or more. Now, using the Mood Disorder Questionnaire or the MDQ, this is a critical step in assessing for prior hypomanic or manic symptoms systematically. It takes time. It helps avoid the most common clinical mistakes by treating bipolar depression like unipolar depression. That's why we always rule out bipolar disorders before we rule in depressive disorders. Lamotrigine initiated at 25 milligrams daily. This is an excellent starting point. It's well tolerated, effective for bipolar depression. But remember, it carries low risk for triggering mania compared to antidepressants, but there's always the possibility of Stevens-Johnson syndrome or TEN. All right, let's take a look at the other responses, unpack those for a second. So option A, diagnosing based on age and starting lithium. So lithium, it's definitely the gold standard as far as mood stabilizers, but jumping to diagnose without formal screening, it bypasses the patient-centered approach. Also, remember, lithium requires routine renal and thyroid monitoring, which isn't always ideal as a first med in a young, treatment-naive patient. Option B, attributing symptoms to stress and then delaying the care. So college stress is real, but this presentation goes far beyond just stress, right? It has a clear mood, cycling, and genetic risk. Waiting a month could allow worsening or a full manic episode to develop. And then option D, starting sertraline for depression. This is very common, and it's a very dangerous pitfall. SSRIs can trigger manic or hypomanic episodes in undiagnosed bipolar patients. With her family history and symptoms, a mood stabilizer and not an antidepressant is the right place to start. All right, so our takeaway here in young adults, rule out bipolar disorder before treating depression. Here's the clinical pearl. When a young adult presents with depressive symptoms, especially if there's any history of elevated mood or family bipolar disorder, don't assume it's unipolar depression. Remember, screen first, treat cautiously, think long term. That's how you protect your patients from misdiagnosis and medication induced mood destabilization. All right, so that brings us to the end of today's structured questions in our live Wednesday sessions. This is where we shift to our open forum and our question and answer section, right? So that brings us to where we get to stick together, go over test taking strategies, talk about why answers are right and wrong, and then the time gets turned to you. And it's really your time to bring to the table whatever is academic, clinical, or personal that may be affecting your studies. So you can ask questions about your semester, what's working, what's not, the review program in general, clarifications on how to get the most out of clarity, material for your studies, so anything confusing or unclear, practice questions. So let's walk through any that tripped you up on the practice exams or in the seminars, or really just anything at all. Anything you want to talk about, this is the time where we can do it in our live session. So this open forum is available to currently enrolled students through a live link on the PMHNP student portal. Just click the link and join the conversation when you've registered. We're here to help you succeed, right? Now, before we wrap it up, I'll leave you with a little word of encouragement here, because this path you're on, it's just not easy, my friends. Okay, but it's absolutely worth it. So sometimes the biggest obstacle is overthinking. You don't need perfection. You just need to start, take action, and keep going. So you always have two choices: your commitment versus your fear. All right, so let's look at this Sammy Davis Jr. quote. Remember, you always have two choices: your commitment versus your fear. So when things get hard, and my friends, they will get hard, remember this: your commitment to your purpose is stronger than your fear. You've come this far. Trust your grit. All right, I will see you next Wednesday at 1900 Mountain Standard Time or 7 p.m. Mountain Standard Time. Keep showing up, y'all. Keep doing the work. You're on your way to becoming an exceptional PMHNP, and we're here to help you every step of the way. Thanks so much. Bye-bye.